Hi, I'm Katie Meyer, and I'm your Montana HOSA State Director. And this video is on how to do a trauma assessment, often known as a rapid head-to-toe assessment for your trauma patient, for EMT specifically. There's another head-to-toe assessment video I'm going to make for CERT. They're slightly different. The skills technically the same, but the rubrics are different. And so you want to remember that even though you know how to do something, the rubric's where you're gonna change points. And in the past few years, the difference between gold and fourth place, I mean, it might only be a number of 1 to 2 points, half points. So you want to make sure that you follow not just how to do something, but the rubrics and that you're saying everything out loud. And the other tip that I'll give in all of these is I tell my students, if you didn't say it, you didn't do it. So if you're staring at your patient and you think that you're assessing breathing, if I don't know as the judge that that's what you're doing, I can't give you that point. I need to know what you're doing. So you need to say, I'm listening and feeling in the mouth for airway movement, or I'm feeling for this certain thing. And so I'm going to walk you through what that looks like. But I would just really memorize, even if you don't have a chance to practice on a mannequin all the time, but at home, just practicing these rubrics and these guidelines word for word, just so that you don't mess them up. And that's why I'm doing separate videos, even though it's kind of the same skill for CERT and EMT, just to show you the nuances of making sure that you hit those points. You could even get out a rubric right now from the short sheet guidelines on the HOSA website or the national website and follow along with me if that's helpful to you. And I'll try not to miss anything because, again, it's so rubric-based versus necessarily maybe what I do in school. So I always start my students off with BSI on, the scene is safe. That stands for body substance isolation. And we're making sure that the scene is safe. The other thing that I'll note, sorry, just kind of bounce back and forth a little bit, is for EMT, this is a really hard one to do if you're not in an EMT program or an EMT class or have finished one. So hopefully as you're going through this video, I'm not teaching you something completely new like you might be learning in some of the other events, because it's a little bit harder. If this is something new to you, you might look at the CERT skills or CPR first aid event instead, just so that you have access to equipment and it might be a better fit for you. So sorry, so starting over, BSI on, the scene is safe, body substance isolation. And I'm going to do a scene size up. So part of that scene size up is making sure that my scene is safe. The judge would have read me a scenario. So maybe my patient was hit on his bicycle and thrown 30 feet, let's just say. So I'm going to then determine the mechanism of injury is a bicyclist versus a vehicle, is what that would be there. And my number of patients at this time is just one patient. I'm going to go ahead and call ALS for backup on this patient for additional needs. I'm assuming that fire and police are on scene already. I might confirm that with the judge and they could tell me yeah. And then due to the nature mechanism of injury on this patient, I'm going to have my ghost partner hold C-spine. So remember, in this event, there's two of you. And so two of you might be doing this whole thing together in a coordinated effort, or there might be two different patients and you might be split up and one of you is working on this patient and the other's working on a different patient. And so they will give you a ghost partner to hold your neck in spinal mobilization. So you could verbalize that somebody is there holding C-spine. The judge might ask to see how that's done, so you might just show them and then they could tell you a ghost partner arrives. But they won't make one person sit here for the entire event and then you're just stuck doing nothing. So just know that there will be somebody to ghost partner and take that over so you can both be going. So then I also determine my general impression of my patient. They might tell me my general impression is poor. They might tell me something like they look really pale. Their eyes are closed when you walk up. You find them laying on their side. Those are certain things that they might tell you in your general impression. And you're going to ask those types of things. Okay, so after I get my general impression, I'm going to then check my patient's level of consciousness. And we do this with AVPU. So A stands for alert, V for verbal, P for pain, and U for unresponsive AVPU. And I go through this series and I stop wherever my patient is. So to know if they were alert, I'm just going to walk up and I'm not going to really say anything to them, because if I say something, then they're responding to my voice. Verbal is my voice, not them being able to speak. So I'm going to walk up and I'm going to ask the judge, are they alert? Do they notice me? Okay. If they say yes, then my patient's awake or alert and I might do something different. But let's say that they're not. I'm going to move you through this scale. So then I'm going to check verbal. Again, now I only want to see if they're alert to my voice. I don't want to check anything else. So I don't want to touch them at this time, because I don't know if they're responsive to my touch or to my voice. So I'm going to ask, hey, sir, can you hear me? And I'll ask the judge, because most likely it might be a mannequin. It could be a live patient. It could be one of the really fancy mannequins, because remember, we're going to use City College this year. And so they do have the mannequins that open their eyes and do stuff. And so if we have somebody that's able to run those computer systems, it could be one of those types of mannequins for you. So I might ask the judge, do they respond? In this case, let's say they don't respond to my V voice. So I'm going to go to pain. Different ways you can check for a painful stimulus. I like a little noogie there on their sternum. And again, they don't respond. I'm going to ask the judge, and so I'm going to deem this patient as unresponsive, U, in my AFPU. So that's my, they're under step 4, part B. And I'm going to kind of look at my general life threats of this patient, and the fact that he's unresponsive, again, confirms that I want some ALS backup, like a paramedic. And I'm going to move on to finding what their life threats are in my primary assessment here. So I'm going to go ahead and do a primary assessment, which starts at step 5, and this is called a primary. It includes your airway, breathing, and your circulation. So I'm going to do that next for my patient. So my airway, I'm going to open their mouth. His mouth doesn't open, but I'm going to go ahead and manually open their mouth, and I'm going to look, listen, and feel for air movement, okay? You're going to ask the judge, what do I find? They're going to tell you clues like you hear gurgling, you hear snoring, you find an apneic patient. And this is where then you'll have decision making. Your rubric's not going to help you as much here, because what would happen now is you'd continue this assessment and a secondary rubric would be added on. For example, you might be asked to take care of the airway with suctioning and an OPA and follow that rubric guideline. So again, if you're 2 people, what I would recommend is somebody else taking control of managing that airway with that rubric, and the next person moving on to B or C in their guidelines. If there's 2 patients, you're going to have to take care of this patient by yourself while your partner takes care of theirs by themselves, and that's okay. So whatever we found here in airway, as soon as we find something in a primary, that's a life threat. So as soon as we find it, we fix it. Find it, fix it in your primary assessment. So let's assume that his airway is okay. I'm going to assume pretty much everything's okay on here today, because I just want to show you how to do the assessment. And then in the other skill videos, I'll teach you a little bit about how to treat some of these things. So I'm going to move to breathing. And in breathing, we also want to look, listen, and feel. So when I feel, I want to make sure that I'm on ribs. And I'm going to feel for a tidal rate, volume, or tidal volume, a rate, and a rhythm. Okay, so they're going to give me numbers here. They might say his breathing is shallow. They might say his tidal volume is normal. They're going to give me a rate. Maybe he's breathing 8 breaths per minute. They're going to give me a rhythm. Okay, you have to ask for these things. If you just stick your hands here and you just say, I'm feeling for breathing, they'll say, yeah, he's breathing, or no, he's not breathing. You need to ask for specifically what you're assessing for. So if you want all those things, that's typically what we look for there. So I felt. I'm also going to look, so I would make him trauma naked typically and expose this chest area. I'm looking for any major wounds. I'm looking for any accessory muscle use type of things. And I'm going to listen. So you're going to get your stethoscope in, and where we want to listen is up high in the armpit. And then again, make sure you stay on the ribs. Don't come down here into his belly, but high on the ribs, and listen both sides, okay? And they might tell you things that you find on one side versus the other, or if they say something like it's bilaterally like this, that means on both sides of your patient there. And then again, if you look at your rubric, it doesn't show you all those things, right? So that's why it's important that you're taking a class or that you know a little bit more on here, because those clues that you got from your assessment then would help you know that they have adequate ventilation there in step B. Because if they don't, you would need to bag valve mask them as one of those other skills. And so you need to decide if you think, based on those clues, that your patient is breathing adequately or inadequately. And so you need to make sure you do that assessment to be able to do those next step on this rubric. This rubric has more critical thinking than some of the others where it's just do on the list. And this is why this is a little more complex event for people. With that assessment, I also need to decide the adequate oxygen therapy. So do I want to bag valve mask him? Do I want to put him on an on breather mask? Do I want to put him on a nasal cannula? Again, a little bit too much more detail for me to go into, and why a class is recommended for this one, and how many liters per minute I'm going to connect him to. So again, make sure you're verbalizing that you're doing those things if you're choosing to do those, and managing any injuries that you might have found here in your B for breathing. the last step of your primary assessment, or the last thing we assess for, is C, circulation. So technically, in the new EMT rubrics with the national guidelines, we do XABC, and X stands for exsanguination. So I would have already also checked for exsanguinating bleeding. That would have been major bleeding as I walked on the scene. So you might ask right as you walk on, do I note any major bleeding? But if I didn't, I could ask for it again here. So I'm going to look for any major bleeds. I'm going to check a pulse. We check a radial pulse here. If for some reason I didn't have one, then I could check a carotid, but I'm going to check a radial pulse. I want to know the rate, the quality of it, the rhythm of that, and that's going to give me clues as to the condition of my patient and what their major life threats might be. I'm going to check their skin color. I'm going to ask the judge that, their temperature, their texture. Sometimes in the judges' rooms they use makeup and it makes it confusing and you don't know whether that's blood or whether they're supposed to be pale from the white makeup. If you're unsure, always ask. And same thing if we use these mannequins, just ask, those things out loud. Again, so I've checked for a pulse. I've controlled any major bleeding if I found any. Again, that would be another rubric. So if you found the major bleeding, then the secondary rubric that would be added onto this would be the bleeding rubric of controlling a major bleed in there. So I'm going to decide their transport priority. I can use the Glasgow Coma Scale, or just based on the fact that if they're unresponsive or they have a major life threat, I'm going to deem them as a high priority patient, and I'm going to ask for ALS backup. Your rubric here talks about obtaining baseline vitals right now. I would only do this right now if you had 2 sets of hands. So if you had another EMT and you were working on the same patient, one of you could maybe work on vitals right now. Otherwise, with a patient who's critical, I'm going to go ahead and wait until I'm en route with my patient to get those. So don't be afraid. You can come back on that on the rubric. If you're worried about forgetting it for just competition's sake, go ahead and think about that. But in real life, I wouldn't want to delay care on this patient if we've decided that they're critical. And maybe you didn't. Maybe they're not a critical patient in the scenario that you have. But if they're critical, you should wait on that. So same thing then with a past medical history. My second EMT, my EMT partner, could be trying to get a medical history from a family member if there was one present. Or if he was responsive, they could be thinking about that too. But this patient's currently unresponsive. So we're going to wait on that medical assessment maybe until we're en route. And we're going to talk about the secondary assessment. And this is that head to toe piece that I was talking about that CERT Skills also does. So you are going to start at the head and move to the toes. And looking for what we talk about is wounds, tenderness, deformities. You might also look for crepitus. Old school EMTs use the acronym DCAT BTLS. Either one is fine, but you want to verbalize that as you go down. Remember, you have a lot of facial bones if you've taken anatomy. There's not just like 1 or 2, so I don't just touch them here and here. I want to really get in there with my whole hands, and I want to check the face and the head. I'm going to look inside their ears. I'm looking, and I'm going to ask the judge, do I see anything in their ears? Do I see any cerebral spinal fluid? Do I note anything abnormal? I'm going to look for battle signs around the back of their neck, which is a bruising pattern with head injuries. I'm going to look at the back of my gloves to make sure that there's no blood on the back of their head, because most people's heads don't float up in the air like this. Okay. As I do that, I'm going to check along the back of the neck and the spine for step-offs. I'm going to check his eyes and pupillary action there, nose and the mouth, that I already kind of looked at those when I checked the airway, but just verbalizing it again for points on that sheet. Then I'm going to check the neck. Okay, on the neck, I'm looking for signs of JVD, jugular vein distension. I'm looking at if their trachea is in line. I also already checked the back of the neck for step-offs. I'm going to do the chest. I already exposed this to look at it, but I also now want to feel the chest. So again, I want to press all along that collarbone and the chest, run my hand down that sternum like this. Make sure you kind of reach back in here a little bit. I already auscultated and listened to the chest during my breathing sound. I might just remind the judges of that. In the abdomen, we always do 4 quadrants, right? So your right upper, right lower, left upper, left lower, and do them one at a time. If your patient was awake, we would verbalize how we would assess if they had pain in one of their quadrants. That's the last one that I would push on, because I don't want to cause more pain that they can't tell which quadrant it's coming from for me. But again, I'm checking for wounds, tenderness, deformities. I'm going to ask the judge if I find anything. They might tell me things like I find distension or different parts along the way. And again, you should know what appropriate treatment is for that. When you get to the pelvis, Okay, we want to press down and in on those hip bones, and we also want to press on that pubis. You can verbalize pressing on the pubis if we have a live patient. Okay, but make sure you verbalize that you would check those things, and that you would check any genitalia area as needed by that injury, because remember those can be, injuries there that can be severe bleeds, as well as tell us about spinal cord injuries in there. Next, we're going to check the lower extremities. You get points for each leg that you check. I like to walk my hands down like this so that there's space, so that if there was some movement and crepitus in those bone patterns, I could feel it, as opposed to this. But again, you want to kind of get in here and manhandle. So I'm going to do that with both legs. Okay. When I get to the bottom, I'm going to check for PMS or CMS. People say it differently. Pulse motor sensory or circulatory motor sensory. So I'm going to check for pedal pulses. I'm going to ask the judge again, do I find anything? What is the rate, or things like that. And then motor, can they wiggle their toes? Okay, can they press up? Can they press down? Either one of those are fine for motor. And then sensory, I'm going to pinch them. Do they respond to this pinching sensation? Again, you're always asking your judge for those feedback items along the way. We do the same thing then with the upper extremities. So I'm going to come to his arms. Okay, and I'm going to walk my hands all the way down the arms. Pulse, motor, can they grab my hands? And sensory, can they feel me pinching them there? At this point, we would be verbalizing that this patient would probably need to be backboarded, so we're going to roll him. Backboarding is no longer one of the skills for this event as of this year in 2020, but you would verbalize how to roll them. So I like to roll one arm up. This mannequin doesn't roll very well. Cross their leg. If you had somebody holding C-spine, whoever's on the head, sorry for the camera movement there, they're going to bounce around, sorry for the camera bouncing around. They're going to go on their head count, so they would count to 3 for us, but we would roll him, okay? And we're going to check his back now. So I'm checking the back for spinal step-offs, any injuries, back, buttocks area, and then I would slide a backboard on. Obviously, my patient wouldn't be on this bed that I have him on for this demo, and roll them onto that backboard, okay? I would verbalize that I would want to package this patient and go now if they were a high priority transport patient. Again, if they weren't, we could take more time on scene and get vitals and ask your sample questions, their sample medical history questions. But again, assuming a trauma that we might be high priority, we could do that en route. So now that we've packaged, I would say that we are en route. And so now I might get my vitals, my baseline vitals. So make sure you demonstrate and show the judges you know how to get a blood pressure, you know how to check pupils. We will not shine a flashlight in a live patient's eyes, okay? Pulses and respiratory rate, which you already got. I would verbalize that you would want to check those probably every 5 minutes for a critical patient, every 15 minutes for a stable patient, knowing that difference is important. And then you might verbalize that if they woke up, you would ask a sample. So you're going to get points for knowing what that is. So, signs and symptoms, allergies, medications, pertinent past medical history, the last thing they ate, and what were they doing when this happened. So if you have an alive patient, you could be getting those information anywhere along this. Again, especially if there's 2 of you and you can be doing 2 things at once as EMTs. And then you're going to get points for making sure that you had good communication, with your patient. If they are an awake patient, did you respond appropriately, or did you totally ignore that they were a human and didn't even talk to them or comfort them or talk to them along the way? Did you do the right treatments? Did you not put yourself and your partner at risk? Okay, and then you're going to go ahead and make a report to the station. So making sure you kind of follow time. If you have a minute left, that you want to make sure you get that radio report in. But you're going to identify who your unit is. From your readout early on, you're going to want to be able to know your patient's age and their gender, their sex. So we're going to call in that you have a 50-year-old male, for example. Their chief complaint. So if they were awake and they told you something, that would be their chief complaint. If they're not awake, what do you think is, some of the worst things that are causing life threats to them? What's their mental status? Remember, that's your AVPU. Their vital signs. What treatments have you tried to do? And then just make up an estimated time of arrival. That doesn't have to be an exact number, but that's what you're going to do for this scenario. Again, you don't know if you're both going to be working on this patient, or if you might each have your own. You don't know if he's going to be critical or if he's going to be stable, or she. A lot of unknowns. So just practicing being able to do that and making proper decisions along the way. Again, I think taking a class is the most helpful way that you would know those things of what to expect to find and how we treat it within our protocols as EMTs. So reach out if you have any questions. Hope you guys are working hard and doing well, and we'll talk to you soon.